Welcome to my presentation for ESSC13005, Advanced Applied Clinical Exercise Science. Today I'll be talking about both my clinical placement and my research project which was completed as part of this course. This is a rundown of what I'll be covering for both topics today. First off, I will talk about my clinical placement. I completed my clinical placement at the Saka Clinic, located at CQ University Rockhampton campus. It's a part of Queensland Health and offers a variety of allied health services such as exercise physiology, physiotherapy, podiatry, and occupational therapy. It's primarily a student-run clinic where university students come in and complete their practical hours. They conduct all of the services with supervisors watching on to ensure that all guidelines and procedures are followed correctly. The main populations worked with at the clinic was primarily older adults with a variety of conditions such as pulmonary conditions. This was primarily in the form of chronic obstructive pulmonary disease or asthma, along with diabetes and musculoskeletal conditions. Many of the clients also suffered from a variety of comorbidities such as cardiovascular disease and neurological disorders. The main tasks I completed throughout this placement was examining client charts to understand the conditions that these clients were suffering from, along with talking with the clients to understand more about maybe how they came to be suffering from these conditions and what sort of treatments they've received and that sort of thing, while also assisting with the paperwork before and after each exercise class, sitting in on the education classes which are run for the client, which is individualized depending on conditions that the clients had. I also sat in on a client intake session where the students run the session to help determine what services they can offer the client, and also sitting in on a case conference where everyone at the clinic meets and discusses a case that has been worked on recently. My contribution to the workplace was we helped reduce the workload on the exercise physiologists and exercise physiology students, which through the helping with the paperwork and getting the clients ready and that sort of thing. We help keep the clients interested and motivated throughout their sessions by talking to them and helping them through things and filling out paperwork for them. And also assisting the clients with the sessions by, if they forget how many sets and reps they're doing, or filling out their RPE on their exercise programs for them. My main learnings from my clinical placement was I got an idea of how health clinics such as this work. I got to see how different allied health professions can work together while also individually, which came mainly through the case conference where each profession had their say on how they would help treat one of the clients. I also got exposure to the exercise physiology profession and learned about some of the procedures conducted by them, along with also the physiotherapists. And I got to observe a more in-depth pre-screening session rather than the regular pre-screening such as the PARQ, which is used in apparently healthy populations. My skill development through my placement, I developed more communication skills, having to talk with a variety of people, whether they were the exercise physiologists, other students, or the participants in the gym. Time management skills, watching how the exercise physiologists manage their time with all the clients and getting them in and out of classes on time. Improved confidence by meeting new people, talking to a variety of different people, and also got to practice taking blood pressure, heart rate and oxygen saturation on other placement students. Finally, a reflection on the experience. It gave an insight into another possible career path. It was a valuable and enjoyable experience and is a career path that I am considering in the future, which would mean possibly undertaking further study in the area. Now I will talk about my research project, which was an analysis of the exercise guidelines for sufferers of chronic obstructive pulmonary disease. Chronic obstructive COPD is ranked as the 5th leading cause of death in the world and is defined as a progressive, irreversible disease. The most common form of COPD is a combination of bronchitis and emphysema, and it's common for sufferers to be suffering from a variety of comorbidities such as hypoxemia and hypertension. A sedentary lifestyle can affect not only the respiratory systems, but also the cardiovascular and musculoskeletal systems of sufferers of COPD. The pulmonary system can be affected by ventilation and perfusion abnormalities, a weakening of the respiratory muscles, and a decreased ability to increase ventilation during exertion. The cardiovascular system, meanwhile, can be affected by a decreased venous return and therefore a decrease in overall cardiac output, while the musculoskeletal system can be affected by muscle atrophy and early muscle fatigue during exertion. However, exercise has been found to benefit sufferers of COPD, which, as it can lead to a greater physical capacity, a decrease in anxiety about their breathlessness, a reduction in fatigue, and a greater quality of life, meaning an increased independence. My choosing of this topic was due to my experiences at the SACA clinic. One client who did not smoke presented with various pulmonary conditions such as upper and lower respiratory scarring. Prior to the diagnosis, they would have been considered low risk. This client sparked an interest in me about pulmonary disease, and due to the broadness of pulmonary disease and the many varieties, I decided upon COPD as the one I would conduct my research on. The ESSC13005 database was used primarily as a research tool. Initially, I searched COPD just to gain a bit more knowledge on the condition, having very little background in it. After that, I consulted the ACSM guidelines to examine the exercise guidelines they recommend for COPD sufferers before returning to ESSC13005 again, using search terms such as pulmonary disease and exercise, pulmonary disease and exercise prescription, COPD, and aerobic or resistance training. The results showed that health screening is primarily the PAR-Q, or in clients who have a negative when completing the PAR-Q, the physical activity readiness medical evaluation, which is used by physicians to determine whether a client is suitable for exercise, and there are also other tools available. Physiological assessment should be conducted prior to exercise prescription, which should include a pulmonary functional examination and determination of arterial blood gases and arterial oxyhemoglobin saturation, and a modified Borg scale using a 1 to 10 scale should be used to determine the perceived dyspnea, and submaximal testing is primarily used using either walking or stationary cycling tests. Exercise prescription comes after assessment. These guidelines come from the ACSM. Guidelines are using the FIT principle, so frequency of 3 to 5 days per week, and the intensity should be at around 4 to 6 on the modified Borg 1 to 10 scale. Time progresses from approximately 20 to 60 minutes, and there is a potential for interval training. The type of exercises used for aerobic exercise uses major muscle groups and incorporates into activities of daily living will progress gradually and is primarily walking or cycling. Resistance training is also frequently used. It's recommended by ACSM to be conducted 2 to 3 times per week on non-consecutive days at a 50 to 80% of our 1RM and progressing gradually. Time is generally 2 to 4 sets of 6 to 12 reps, and once again, large muscle groups using a variety of either bodyweight exercise or resistance band exercises and progressing onto machines or dumbbells. Finally, reassessment is used to ensure that participants are progressing in their programs. It's generally conducted using similar tests that are used during the pre-assessment and are generally conducted around 3, 6 or 12 months into the program depending on how long the program is. Other tools are frequently used in a clinical setting for pre-screening. These include the physical activity scale for the elderly and the Stanford Brief Activity Scale. These tools are primarily for older adults, while tools such as the Medical Research Council Dyspnea Scale and the ADO Index, which is the Age Dyspnea and Airflow Obstruction Index, and the Stanford Self-Efficacy for Managing Chronic Disease 6-item scale are primarily to pre-screen for pulmonary diseases. The physiological assessment. The most common form of physiological assessment is the 6-minute walk test, which is measuring the distance walked over a 6-minute period. Throughout the test, it's common for RPE, pulse oximetry, and heart rate to be taken. And a few variations to this test include the 12-minute walk test, incremental shuttle walk test, and endurance shuttle walk test. These can be used depending on the client and their personal limitations. Other forms of assessment can be used include spirometry and electrocardiography. These are more prevalent in research settings rather than clinics due to the time constraints and costs involved in a clinic. However, heart rate, blood pressure and oxygen saturation should be monitored throughout pre-assessments. In exercise prescription, aerobic exercise has long been considered the gold standard for exercise with sufferers of COPD because it decreases ventilatory demand at a given workload, decreases airway sensitivity, improves vital capacity, and improves alveolar gas exchange, while resistance training often targets smaller muscle groups and has been found to improve peripheral muscle force, muscle endurance, and whole body endurance. Generally, clients will be prescribed both aerobic and endurance exercises, with aerobic exercises being longer than 5 minutes and resistance training targeting the whole body with 2 to 3 sets of 12 reps for each exercise. And heart rate, blood pressure, oxygen saturation, and RPE should be measured throughout the session, either periodically throughout the session or before and after, while reassessment will generally occur at the completion of the intervention period, which will usually be anywhere between 6 and 12 weeks, and once again is usually a repeat of tests completed during the pre-assessment. Therefore, in conclusion, exercise can have beneficial effect on both the physical well-being of sufferers of COPD, while it's also important for the exercise prescriber to take into consideration the individual requirements of a client. And the practical implications of this report is that it can be used as a tool to examine exercise guidelines which are specific to COPD patients, and it also examines the effectiveness of guidelines and their appropriateness for this population. Finally, just a few references, and that is all. Thank you.